All right, here we have part 2 of the stable program's cardiac section. This is evaluation and stabilization of neonates with CHD, and we are going to get a little bit deeper into these different congenital heart defects. All right, so how do we get a tentative diagnosis for a kid with CHD? They list a bunch of stuff here, signs of poor cardiac output, respiratory distress, tachypnea. I would say that for myself, chest x-rays are going to be incredibly helpful at diagnosing a CHD, but having persistent central cyanosis, having poor feeding, having a comfortably tachypnic baby, having a very irritable baby that doesn't feed well, doesn't sleep well, has a myriad of other GI problems. I would start to think CHD for some of those babies. The comfortably tachypnic cyanotic baby. If we know that the baby has a diagnosed congenital heart defect from birth, during the prenatal phase, then obviously we don't need to really go very far into our differential. We're going to have something handed to us. But if we know that mom has had other family members or brothers and sisters that have congenital heart defects, if mom had a lot of alcohol or recreational drug use during her pregnancy, or had a viral exposure that caused high fever during pregnancy, you can have an increased incidence of CHDs with those as well. During the actual delivery itself, if she had any type of perinatal hypoxia or sepsis or anything like that, then you can have an increased incidence of these heart defects as well. And then when the sick baby comes into the facility, or when the parents call you guys to go do an evaluation, and you see this sick baby, are the presenting symptoms typical of like a pulmonary issue, like they have lung sound changes, and and their chest X-ray shows like air bronchograms and things like that, or are they that comfortably tachypnic kid who is cyanotic despite being on oxygen, or do they have an obvious infectious issue going on? Do they have a neurological issue like hydrocephaly or something like that, or do they have other metabolic diseases? So it's important to be able to differentiate the symptoms into a category of where our differential is heading. And as far as a physical exam goes, as it says there, exam findings can definitely overlap, but be alert for things that indicate heart defects, like pulse ox differences between the right hand and the left foot, looking at a chest x-ray, and looking at different EKG findings. And the first thing that they look at here is a chest x-ray, and right here they're looking at that cardiothoracic ratio. So essentially, if you're looking at this chest x-ray right here, you can see the cardiac silhouette. You can see it on the right side of the chest, marked by A there. That's the widest horizontal diameter of the heart right of the midline, and then B is going to be left of the midline. Those two together should be about less than 60% of the entire diameter of the chest. So the entire silhouette from A plus B should be less than 60% of C. And if you have a larger diameter than that, as shown in both of these chest x-rays on this page, then you have some sort of problem. So if you have increased pulmonary vascular markings, which I'm not going to get super deep into x-rays, but you can see right here, this is the hilus. You actually can't see the hilus on this baby's chest x-ray on the left side because his heart is so big, but you have a lot of increased pulmonary vascular markings. Obviously, you've got increased pulmonary vascular markings and some pulmonary edema in this one right here. And so if you have increased pulmonary vascular markings with an associated humongous heart, then typically you're going to be looking at left heart outflow obstructions or some sort of increased pulmonary blood flow problems. So the baby's able to put blood out to the heart, but is for some reason unable to take that blood and push it out to the rest of the body. So you get a bunch of pressure building up in the lungs, and you have those increased pulmonary vascular markings. oftentimes associated with a cardiac hypertrophy as well. We're going to talk about the total anomalous babies here in just a little while, so I'm not really going to get deep into this one, but essentially if you have a completely whited out lung with no air bronchograms or anything like that, with some associated pulmonary edema, as we see in this chest X-ray right here, pretty bad indication, especially in combination with it being a normal or even a little dinky sized heart. You can see that this heart right here, the silhouette comes out to right here, and then the silhouette comes out to right here. So a pretty darn small heart for these kiddos, probably a huge obstruction for pulmonary blood flow getting back to the left side of the heart somehow. And this is a TAPVR baby, which we'll get into here in just a little while. If you have a reduction in pulmonary vascular markings, so you've got that really blacked out looking chest, then start to think about right heart obstructions, right? So if you do not have a lot of blood flowing into the lungs, then that means that somehow blood was not able to leave the right side of the heart and get into the left side of the heart. So we do not want to see decreased pulmonary vascular markings. That's very indicative of some sort of heart defect. Just like in the last slide, if you have decreased vascular markings with some increased heart size, then we could be looking at some other anomalies. Probably not important for you to be like, oh man, there's decreased peripheral vascular markings with a large increased heart size and an upward apex, so it has to be Ebstein's anomaly. Not important for you guys to know those types of things. In this chest X-ray, we see some pulmonary hemorrhage up in this area. See some big pneumos in this one. You can see the outline of the lung right here, and that should obviously be next to the chest wall. Same thing with this is the outline of the lung right there. So you've got a pneumo up here and a large pneumo on this side as well. You can see the cardiac silhouette a little. You can see it pretty well on the left side. You can't really see it very well on the right side, but this baby has some air leaks for some reason, and so it developed bilateral pneumothorax or pneumothoraces. I've mentioned it a few times. These are the ground glass appearance on this. Very difficult to see the cardiac silhouette, just kind of looks whited out. And then you see these little streaks of black coming out of the X-ray right here. And those are air bronchograms, which is indicative of some sort of atelectasis, and is a very common finding with respiratory distress syndrome in the newborn. Which is RDS is due to a surfactant insufficiency. Very common to see RDS in preterm babies less than 32 weeks, and that's what that is caused from, is a surfactant insufficiency. Right here we see a diaphragmatic hernia on the left side. Got a diaphragmatic hernia right there. All those loops, those are bowel loops. And so bowel loops in the chest, no bueno. This kid needs to be immediately decompressed, needs to immediately be intubated and ventilated. You can actually see what looks like a little pneumo on this side as well, down here. Pleural effusions, not always easy to see a pleural effusion on a baby. Some other things that we can see on this chest X-ray, though, is we see a crazy increase in pulmonary vascular markings, and so that means that the right side of the heart is pushing blood to the lungs, but for some reason the lungs cannot get back. The lungs cannot drain their blood back into the left side of the heart very well, and this baby happens to have critical aortic stenosis. But anytime you see these whited out lungs with the increased vascular markings, that's no bueno. When you're looking at the bottom of a chest X-ray where the diaphragm meets the ribs, it should be very clear in edge. It should be a very, very sharp, clear edge. And if it's kind of rounded like this, then that is indicative of a pleural effusion. All right, so let's look at the difference between pulmonary and cardiac diseases. So is a patient going to be cyanotic with a pulmonary and a cardiac? Yes, they are going to be cyanotic with both of those. Respiratory rate, typically they will be tachypnic, Work of breathing will be will definitely be increased with a pulmonary disease. Oftentimes it is going to be easy or comfortable tachypnea. With a cardiac issue, the work of breathing does increase as the disease process continues and the babies start to develop heart failure. Acid-base abnormalities, this is where you will this is the single place where you will really definitively make a differential between a pulmonary issue and a cardiac issue, is that with a pulmonary issue, you're going to have a respiratory acidosis, whereas in a cardiac issue, you'll always have a metabolic acidosis. So that's why ABGs are so important with these kiddos. Trying to differentiate between a pulmonary and a cardiac issue is their ABG. Chest X-ray, it can be different between the two. Oftentimes with a pulmonary issue, whatever the problem is in the lungs, be it like a pneumonia or something like that, it's going to be isolated in one area of the lung, and so you'll have those consolidations or infiltrates in just one lobe or in one part of the lung, so you'll have this asymmetric pattern. Oftentimes with a cardiac abnormality, as you saw in those previous x-rays, you'll have an increase or a marked decrease in pulmonary vascular markings, but oftentimes it's going to be symmetric between the two sides of the lungs. Heart shape is normal in pulmonary issues. It's also normal in many cardiac issues as well, but it can be abnormal. You can have a hypertrophic heart in those cardiac babies. And then an O2 challenge test, essentially you put them on room air and then you give them a bunch of oxygen until they or you give them 100% oxygen. If their PO2 goes above 150 millimeters of mercury on their ABG, then you know that their issue for their poor saturations is a pulmonary issue and not a congenital heart defect with mixing of venous and arterial blood. Because if you have, if you do an O2 challenge test and their PO2 does not go above 150, then that means they have mixing, so they have a cyanotic lesion or a cyanotic congenital heart defect. All right, there's 4 different kinds of congenital heart defects. We have non-ductal dependent, which encompasses 15% of all CHDs. We have ductal dependent, which are 9%, and then we have left outflow tract CHDs, which are basically also ductal dependent, just for a different reason. And then about 60% of congenital heart defects fall into that other category, where they are maybe a mixture of a lot of different things. The first one we're going to talk about is non-ductal dependent lesions, which accounts for about 15% of congenital heart defects. All right, so the first one we're going to talk about is Tetralogy of Fallot, which is probably one of the single most common types of congenital heart defects. It is responsible for about 10% of all CHDs worldwide. And then we are going to talk about Truncus. We're going to talk about that TAPVR baby, that total anomalous pulmonary venous return, which are very rare. And then we'll talk about that Ebstein's anomaly as well. You can see that little caveat there at the bottom that with TET babies, oftentimes they are non-ductal dependent, but if they have a super horrible pulmonary atresia or some sort of pulmonary like outflow obstruction, then they may be ductal dependent, and then they would fall into another category. We'll talk about that in just a few minutes here. All right, so congenital heart defect that is non-ductal dependent. What that means is that the PDA or the Ductus Arteriosus, not the PDA, the DA, which is the Ductus Arteriosus, which is the duct that connects the pulmonary artery to the aorta during fetal circulation, is not required for blood to get to the lungs or to the body. And so with ductal dependent lesions, oftentimes when we refer to as a heart defect as a ductal dependent lesion, oftentimes what we're talking about is a right heart problem where it can't push blood to the lungs, and we need to open that ductus arteriosus. We need to create a PDA in that patient to get blood to the lungs. When we have a different category, that other category of that left heart outflow obstruction, meaning oftentimes you're going to have valvular issues or some sort of aortic, either stenosis, coarctation, or some sort of atresia, that patient can get blood to their lungs, but they can't push blood out to their body very well. And so with those patients, they are ductal dependent because they need that ductus to open up so that they can mix blood from their pulmonary artery and put it into the rest of the aorta to increase the blood flow coming out of the heart. So just understand that the ductus arteriosus is not just for babies who can't get blood to the lungs. It's also for babies who can't get blood from the lungs to the rest of the body. So, but the first thing we're going to talk about here is non-ductal dependent lesions. Understand that any type of problem is going to lead to some sort of central cyanosis with these CHD kids because they have mixing of desaturated blood with saturated blood. This is actually a pretty good page, really wordy, but pretty good page as far as a general approach to all CHDs. If you have a neonate with suspected congenital heart defect and you're not exactly sure which one it is, we are going to treat them basically the same. We're going to provide 100% oxygen. We're going to evaluate and treat for different signs of shock. If they need inotropic support, that's totally fine. We're going to rule out pulmonary disease, or we're going to try to rule out pulmonary disease. And if CHD is suspected after you try to rule out other things like sepsis or a pulmonary issue or something like that, the problem is going to be probably ductal dependent if your oxygen saturation remains below 75% despite trying to give them 100% oxygen. And if their oxygen saturation still remains below 75% after trying to resuscitate them, probably consider starting prostaglandins. And really that can encompass like any of the ones that we're about to talk about right now. But we are going to delve into all of these different ones. Not really going to talk about the normal cardiac structure and blood flow of the heart. It's all pretty obvious for you guys. Comes in the right side, goes out to the lungs, comes back from the lungs into the left side, and then goes out to the body. Everybody listening to this, I am 100% sure, knows that the heart is a two-sided, four-chambered pump that has like blood vessels and stuff coming in and out of it. All right, so tetralogy is going to be the first one we talk about, very commonly referred to as a TET baby, and tetralogy means four, or TET means four, and so that means that these kiddos have four problems with their heart. The four problems with a TET baby are as follows. They have a VSD, could be small, could be very large. This baby happens to have a pretty large ventricular septal defect. You can see a big hole in their interventricular septum right there, so they have a VSD. The next thing is right ventricular hypertrophy, which is oftentimes because of the next portion of it. So, and I'll come back to this right ventricular hypertrophy in just a second. But the third aspect is that they need to have a right ventricular outflow obstruction. We can see right here that they do have an outflow obstruction. This is a subvalvular outflow obstruction. They can also have a valvular problem, or they can have a supravalvular stenosis of the actual pulmonary artery itself. This one is actually very mild. That's pictured right here. And because the right ventricle constantly has difficulty pushing blood out to the pulmonary artery, you get that right ventricular hypertrophy. And then the last portion of a TET baby is that they have an overriding aorta, which means that their aortic opening right here is huge, is way bigger than it should be. That also makes the mitral valve opening a lot smaller, but it's actually kind of helpful with the mixing that they're having right now because it allows more blood to go out of that aorta. So it's going to relieve some of that right ventricular stress. All right, so if you have a pulmonary outflow tract or a pulmonary artery that has adequate blood flow to it, you'll notice that this baby is going to be cyanotic, but not horribly cyanotic. So as that blue blood is coming in the right side, going into the lungs to be oxygenated, it comes back from the left side of the heart, well oxygenated, and then as it mixes through that VSD going out that outflow tract, or excuse me, out that big overriding aorta, it's only mildly cyanotic blood coming out of that heart. If you have an incredibly stenotic pulmonary artery, then you're going to have much less outflow from the right ventricle. You're going to have an increased amount of shunting from the right to the left ventricle, and you're going to have much higher mixing of cyanotic blood. Plus, you're going to have reduced amount of blood being oxygenated in the first place in the lungs, and so you're going to have a much more cyanotic looking baby. Clinical presentation for TET varies depending on its severity, but if you have a baby who's pink and then maybe during feedings or during a TET episode, they start to become a little bit cyanotic and then they recover. It can be oftentimes difficult to diagnose. They may not even have a TET diagnosis until they're closer to like maybe 1 year of age, whereas a moderate to severe stenotic baby, those cyanotic or blue TET babies, they have a huge right to left ventricular shunt, as is shown in this picture right here on the screen, and you have a very cyanotic looking baby, so you get a very early diagnosis for these kiddos. You may hear a murmur because of the VSD, you may not. Chest X-ray on these kiddos, you can see on this particular kid that you have a little increased pulmonary vascular markings. You do have that very typical textbook boot-shaped heart that is common with TET babies. You have this upturned up apex because you have all that right ventricular hypertrophy. So you have that kind of that large RV that's causing the heart to turn up a little bit. And you can see that they have like normal, maybe even a little bit high pulmonary vascular markings on this chest X-ray. But as the pulmonary stenosis or the pulmonary atresia gets worse and worse, then you're going to have decreased vascular markings because you're going to have decreased blood flow to those lungs. Initial stabilization of basically all of these kids is going to be the exact same, right? So we want to provide O2 to maintain SATs greater than 75%. If SATs cannot go above 75%, they either have something else going on or they have such severe pulmonary stenosis that they are not perfusing their lungs very well. So we actually would like to encourage a little bit of mixing of blood coming from the aorta to go back into those pulmonary arteries. And so if we can't get their SATs above 75%, we're going to start prostaglandins to encourage mixing of blood right here if they do have a severe pulmonary stenosis as pictured in this. So while TET babies are non-ductal dependent, they totally can be if it's severe. The next thing we talk about is Truncus. Truncus type 1, there's a few of them, but or two of them really. But Truncus is shown right here, type 1, and it's pretty easy. Basically, you have a big VSD, and then instead of an aorta and a pulmonary artery, you just have one big trunk coming out of the heart, and that's why they call it Truncus Arteriosus. Because of that VSD, you have pretty equal mixing of blood, but an adequate amount of blood is going to the lungs, an adequate amount of blood is coming out of the aorta. These babies are going to be a little cyanotic because they are mixing blood through that VSD, but otherwise they're typically not going to be sick, or excuse me, they're not going to be crazy sick, and this is non-ductal dependent. You can see the mixing right there. And then these are the typical presentations of CHDs, right? So you have mild cyanosis at birth. It may get a little bit better. When they go home, they're going to have that comfortable tachypnea because they're mildly cyanotic, or they're mildly hypoxic rather. They may be a little diaphoretic. They're going to be poorly feeding, or they may become very diaphoretic, even cyanotic during feeding, and then can show signs of CHF at several months of age. If you are an expert with listening to lung sounds and systolic and diastolic murmurs, then you may be able to pick up on this. I am definitely not that person. This is going to be something that's going to be diagnosed with an echo. Looking at the chest X-ray for these Truncus babies, they do have some pretty good cardiomegaly on these, and about 30 of them. Very difficult to see on this chest X-ray, but about 30 of them have a right aortic arch that drops down this way. This kid does have has a left aortic arch coming down right there, but it's very difficult to see on this chest X-ray. Initial stabilization, always and forever, not any different, right? So you're going to start them on oxygen. Your target oxygen saturation is greater than 75%. And with truncus, having those deletion syndromes like that de George syndrome and stuff like that is a common finding is to have this Truncus Arteriosus. And so if you do have a diagnosis of truncus, you need to start checking for other things. The next one we talk about is that total anomalous pulmonary venous return. What a confusing, stupid mouthful that is. But you can just take the total and anomalous away and just say abnormal. That's all total anomalous means is like abnormal. So you have abnormal pulmonary venous return. There's three types. The most common is to the left. The least common is to the right. So you have the supracardiac TAPVR baby. You have cardiac and then you have infracardiac. Essentially what it is that blood goes out to the lungs, but then as blood comes back from the lungs in the pulmonary venous side, those pulmonary veins did not develop correctly, so they go somewhere else. You can see the supracardiac ones right here, the cardiac, and then the infracardiac, how all those blood flow through the heart and mix together. And we'll talk about them a little deeper here in just a sec. So this is the supracardiac, which is the one that was to the far left. It's the most common one. 50% of TAPVR babies have this. And you can see that tract right there. So as the pulmonary veins come back from the lungs, instead of dumping into the left atria, they come up through this shunt, back up into the superior vena cava, dumping back into the right side of the heart. And then you have mixing through either a patent foraminal valley or through an atrial septal defect right there, dumping now oxygenated, mixed oxygenated blood back into the left atrium. A cardiac TAPVR is one where there is a small confluent drain from the back of the heart into the back of the right atrium. So those pulmonary veins dump into the right atrium directly, and then it mixes through that PFO back into the left atrium. These ones are usually you can pick these cardiac ones. You can see how much stuff is going on in the top part of that heart and that in the top part of the mediastinum. And so typically on chest x-ray, these kiddos are going to have like a widened mediastinum on chest x-ray. And then the infracardiac one, these are the ones that are the sickest. So that little pulmonary venous drain drains all the way down through the diaphragm, down back into the portal system, and then mixes with a bunch of deoxygenated blood going through the liver and the portal system, going back into the inferior vena cava, and then it mixes from right to left through that PFO as well. Really sick babies that have this infracardiac TAPVR mixing. And so definitely these kiddos are going to have to do some surgical intervention pretty quickly. You can see just how dark and purple that mixing is on these infracardiac ones. These are, as I said, very sick babies. So they'll be profoundly ill shortly after birth, can mimic like severe lung disease. Typically they'll be tachypnic. They can develop a pneumo as well, especially because they have a little leak or an extra hole coming down out of the bottom of their diaphragm. So just all badness happening with these little infracardiac ones. One little side note about these ones is that you can see down at the bottom where that pulmonary venous drain goes back into. So on the back side of the heart here, this big fat pulmonary venous drain dumps back into the portal system, or the hepatic vein into the portal system. It almost looks like it's a little aneurysm, or it's got like a little aneurysm almost, and it's because it's got a lot of pressure behind it, because it's only allowing a certain amount of blood to get back into this portal system. And so you'll get a lot of backing up of blood into these pulmonary veins, and then you'll end up with pulmonary hypertension, pulmonary edema, just like you would with left heart failure. Because of that, on these kiddos, you can see these huge increases in their pulmonary vascular markings and pulmonary edema. These look totally whited out and almost like a little ground glass. just like in the respiratory distress syndrome kids, but the difference is that there's no dark streaks. There's no air bronchograms in this to make it look like a respiratory distress pattern or an RDS pattern. Initial stabilization is going to be essentially no different than anything else. The only difference with these ones is that you are probably going to need to support their respirations via intubation, but otherwise you're still placing them on high flow O2. You're treating any other types of shock or acidosis. You may have to give them some inotropic support, be it dopamine or whatever, and then they are going to need to have some surgical intervention for these kiddos. Ebstein's anomaly, it's a very rare anomaly. It accounts for less than 1% of all congenital heart defects, but essentially it's a completely incompetent tricuspid valve on this left side, or excuse me, on the right side of the heart. You can see all the chordae tendineae are just holding the tricuspid valve open. Oftentimes it can create like a mechanical outflow tract obstruction for that pulmonary artery, which is really bad juju for those kiddos. But that's all it is tricuspid regurgitation. It's going to cause the right side of the heart to have to work a ton, and so you're going to have this this like right ventricular hypertrophy, but you're also going to have a hypoplasia of the actual muscle itself. You can see a thinning of the muscle wall on that right ventricle, and just not good. You'll see that heart be very, very big on chest X-ray, huge on chest X-ray. On these kiddos, you can see the flow. You do have a patent foraminal valley and or an atrial septal defect that allows for mixing of blood. Oftentimes with these kiddos, this part of the tricuspid valve may impinge the right ventricular's ability to push blood up to the pulmonary artery as well. These kids are going to be severely cyanotic. They're going to have potentially some hypoplastic lungs as they are not able to push blood out to them. Going to have that weird gallop lung sound, which is very common with these kiddos. That gallop sounds like a horse running on lung sounds, and it's because of that big, flappy, incompetent tricuspid valve. And as stated, they have like big, huge cardiomegaly. So you can see that they've got that big balloon-looking shaped heart. Their cardiac silhouette takes up about 80% of their total pleural space, which contributes further to their big hypoplastic lungs that they have. Ebstein's abnormality is no different. We need to provide O2. Very, very horrible extreme forms may be ductal dependent, especially if that PFO is closed. And so we can consider giving prostaglandins if we cannot get their SATs above 75%. All right, so we talked about non-ductal dependent lesions, which accounts for about 15-ish% of all congenital heart defects. Now we're going to talk about ductal dependent. Ductal dependent, we've got transposition, we have tricuspid atresia, pulmonary atresia, and then we have a severe TET or a severe Ebstein's abnormality. Remember that ductal dependent lesions, when we say this is a ductal dependent congenital heart defect, what we're really talking about is typically without a patent ductus arteriosus, the child would not be able to put an adequate amount of blood into their lungs. And so remember that the ductus arteriosus shunts blood from the pulmonary artery into the aorta during fetal circulation because we don't need to circulate the lungs during the first 9 months after conception. And then that PDA closes within hours to days of life and is fully shut and turns into the ligamentum arteriosum within about 4 weeks of life. Here it's showing you the difference between a ductal dependent heart for systemic blood flow and a ductal dependent heart for pulmonary blood flow. So for the one on the left, you have a patient who, this is actually a coarctation heart that we're looking at right here. It's got a bilunar valve on the aorta instead of a instead of a semilunar valve, and then you can see the coarctation right there, that's the most common place for coarctation. But and we'll talk about coarctation here in just a few minutes if you're not seeing what I'm showing you. But essentially, for this kiddo on the left, you can put an adequate amount of blood flow to the lungs, but because of the coarctation and probably because of the incompetent bilunar valve, you're not able to push a bunch of blood out to the body, and so you'd have a really diminished output through the aorta. And so having a PDA in this instance, a right to left PDA, is very important, because then you can at least, even though it's mixed blood, you can at least put a bunch of blood into the aorta to maintain a cardiac output. In this baby right here, I'm actually not seeing what the problem is for this heart. I don't think they actually did an abnormal heart, but this is just to show you that if for some reason you're unable to push blood out to the lungs because of an incompetent pulmonary artery or some sort of right ventricular problem, that if you have a left to right shunt through the PDA, this aortic blood is going to mix in here to the into the pulmonary artery and push blood out to the lungs. And so these ductal dependent lesions that we're talking about right now are for left to right shunt for ductal dependence. All right, so talking about a PDA, right? So a PDA in this incidence for ductal dependent lesions, it is required for pulmonary blood flow, right, to improve that pulmonary blood flow in these patients. How do we open up the ductus arteriosus? We do it with prostaglandin E1, and it maintains the patency of the ductus arteriosus. Essentially, it is a smooth muscle relaxer and maintains a vasodilation of that ductus arteriosus. What we are wanting to do is, depending on what kind of lesion it is, we either want to improve systemic blood flow or we want to improve pulmonary blood flow, depending on, like I said, what kind of lesion it is. The main goal is to improve oxygen saturation and or blood pressure in our babies. The dose is going to be protocol dependent. The dose that they list here is that 0.05 to 0.1 mics per kilo per minute, and you can go up to all the way up to 0.4 mics per kilo per minute if you absolutely need to, and there's no response to your initial stuff. Your expected response is that you're going to have an increase in your an increase in your partial pressure of oxygen in your arterial blood, or an increase in blood pressure, depending on what type of lesion it is, and you'll have an improvement in the acidosis. A couple rules with prostaglandin: it doesn't play well with others, so you need to have a separate line for it, and it's a continuous infusion. Once you get to the results you want, you can start to decrease the dose a little bit. Test question here: if you are planning on taking the FPC or the CFRN, especially if you're looking to do the CNPT exam at any one point, the number one side effect of prostaglandin that you need to look out for is going to be apnea in the first few hours of the infusion. And it has a myriad of other issues. I mean, it's a smooth muscle relaxer, so you can see that you could probably have some cardiac changes. You could have some hypotension, CNS changes, gastrointestinal changes, right? It's a smooth muscle relaxer, so you can have a little diarrhea. All right, so our first ductal dependent lesion right here, we have transposition of the great vessels. So you have your aorta coming out at the top of your right ventricle and your pulmonary artery coming out of the top of your left ventricle. That's if you are not an expert at heart stuff, you probably can still pick up on the fact that that's like not a good thing to do. And so you have complete transposition of those two vessels coming out of the heart. So all the deoxygenated blood's going to the body, and all the oxygenated blood is recirculating to the lungs in just a circle, and that's no bueno. In order to maintain life with these kiddos, you have to maintain a patent ductus arteriosus, plus you will need to maintain a patent foramen ovale between the left and right atrium. You can see that is where the mixing is occurring right there with that red arrow. Here you can see blood flow and mixing with a closing ductus arteriosus. You have very profoundly cyanotic baby. and you only have a little bit of mixing from the left atria to the right atria. Once you start prostaglandin therapy and you reopen that ductus arteriosus, you're going to have a lot more shunting from right to left and then back from left to right, and so you're going to end up having much less cyanosis, and actually the baby will probably have oxygen saturation a little bit higher in their legs than they would in their arms. So presentation for these transposition babies, and keep in mind this is with an intact ventricular septum, right? If they have a big VSD, they're going to have left to right mixing through the ventricle and going to be a little bit less sick, but they are definitely going to be very cyanotic when they are born, and they're going to have that comfortable tachypnea that progresses into a sicker and sicker and sicker baby. The clinical presentation, on the other hand, if they do have a large VSD, will depend on how big it is and how well it mixes from the left to the right, and they may not have that horrible of skin signs in the beginning, but then they will progress into failure as that ductus arteriosus starts to close. As I said just a few minutes ago here, it's like a really weird presentation with these transposition babies where you have a lower oxygen saturation on the right arm than you do basically anywhere else on the body, on the left arm or down on the feet. Whereas if you have a lot of these cardiac abnormalities, you'll have higher saturation in the right arm than you will in the rest of the body. And this, with transposition, it is the opposite. Chest x-rays for these babies, they have that little egg on a string textbook thing to them. I have a hard time appreciating that. I mean, I can see that maybe the left-leaning egg-shaped heart, but I am not appreciating a very narrow mediastinum on these babies, especially because it's such a small space anyway. But that is some of the findings that you're looking for up at the top of the heart, to have a very narrow mediastinum as those two great vessels align over the top of each other instead of being side by side. Initial stabilization is no different than anything else we've done. We're going to give them some O's in order to reduce their pulmonary vascular resistance. Remember that an increased oxygen concentration in the body for neonates is going to lower their PVR. And so we want to maintain a right arm saturation. Remember, that's going to be the low saturating arm in these transposition babies. We want to maintain right arm saturations greater than 75%. We need to begin prostaglandin infusions in these babies until they improve. The Rashkin procedure, they're going to come up, and this is really only with like a persistently sick kid that is still sick after prostaglandin therapy. What they do is they go in with a balloon, they go in from the inferior vena cava through the PFO, and then they insert it into the left atria. They then blow the balloon up and kind of yank the balloon back out the PFO to kind of rip it open a little bit, which is horrible, but it greatly improves the left to right atrial shunting on these babies, and so you're going to have a pretty big improvement in their saturation. So you can see the balloon, and then they rip it out of there in order to improve that left to right atrial shunting. And so you have an improvement in the oxygen saturation. Tricuspid atresia. Atresia means a blockage, right? So if you see something that's coarctation means that it is a stricturing or a stenosing of something, but atresia means that the pipe is not a pipe. And so tricuspid atresia is a very dangerous heart issue, and what it is that the tricuspid valve never developed, and so it never allowed a pathway from the right atrium to the right ventricle. That causes the right ventricle to be teeny, tiny, and causes the rest of the heart to have to work a ton. You can see on this picture right here that the tricuspid valve does not develop, and so all of the blood from the right atrium is having to shunt over to the left the left atrium to that foramen ovale, or they may have a atrial septal defect as well. And then the blood is traveling down into the left ventricle and out to the aorta. And so very poorly oxygenated blood, because the only way that the lungs are getting oxygen is typically from a small ventricular septal defect from the left ventricle to the right ventricle. So it's pushing that blood into that little dinky right ventricle, and that hypoplastic right ventricle, and then it's pumping just a tiny bit out of blood up out to the lungs. You'll notice in this picture too that the pulmonary artery looks like it's a little incompetent too, or a little stenotic, and so even has less blood flow than it should otherwise be able to handle. So this tricuspid atresia baby is super sick. So tricuspid atresia with a ductus arteriosus that is closing. It's just the picture that you just saw, right? So really no mixing at all in a really, really cyanotic sick kid. But if you open up that ductus arteriosus and allow some of that blood to mix back into the pulmonary artery and then go out to the lungs, you're going to have a much better flow of blood into the lungs, oxygenating them a lot better. So that way, when it mixes from the right atrium to the left atrium, you're going to have improved oxygen coming out of that heart. I could almost just say all of these present exactly the same, because they really do. They're going to be cyanotic, they're going to be comfortably tachypnic, they're going to be feeding like crap, and then as they get worse, their cyanosis is going to get worse. And if they have worsened pulmonary stenosis, then they're going to get worse. If their ventricular septal defect starts to close, then they're going to get really, really sick, probably just die. But these kiddos are definitely very, very sick kiddos. Chest X-ray, heart side's normal. Remember that you're going to probably have some decreased pulmonary markings because you are not able to push a bunch of blood out to the lungs. Can't really appreciate that on this X-ray very well. I think they got maybe a little too good of exposure on that X-ray. But yeah, you should see a little bit decreased on those pulmonary vascular markings. Treatment's going to be no different than anything else. We are going to give them some oxygen, get their sats above 75%, start them on prostaglandin to improve that aortic to pulmonary artery shunting, and they need some surgery. Lots and lots of surgery. Pulmonary atresia, remember, atresia is where the pipe is not going all the way through. So this is pulmonary atresia with an intact ventricular septum. So this baby does not have a VSD. You can see in this particular picture, the actual pulmonary artery does not look stenotic, and it looks like it is intact going out to the lungs. And so in order for this pulmonary artery to be atretic, then it has to be the valve, right? And we can see on the picture that it's not a semilunar valve, that it looks like it's just a singular monolunar valve that is not opening and closing. So not allowing any blood flow to get from the right ventricle into the pulmonary artery, and we just have a bunch of blue nasty mixing. Very, very sick baby. Once we open that PDA and allow that aorta to start mixing with blood into the pulmonary artery, then we can start oxygenating blood here. Still going to be a pretty cyanotic baby, despite prostaglandin. And now we've got tetralogy with pulmonary atresia. Remember, tetralogy, you have that big ventricular septal defect, and so at least you have mixing in that respect. But unfortunately, if you have more than just a stenotic pulmonary artery and you have complete pulmonary atresia, the only way that these babies are putting blood into the lungs is through the ductus arteriosus. And so if we don't keep it open, they're just going to die. And you can see that it's very, very cyanotic and very nasty looking in purple. But as soon as we can open that thing back up, now we are getting a lot better mixing, and we are going to have a less cyanotic baby. both pulmonary atresia with an intact ventricular septum and then a TET baby, a tetralogy baby with pulmonary atresia are very similar, very significant deterioration as the ductus arteriosus closes. A coworker of mine actually had a baby that had this out in the field probably 8 or 9 years ago, and he can definitely tell you how much he was able to appreciate that significant deterioration as soon as that ductus was starting to close, for sure. Murmurs, like I said, are always going to be present with a lot of these things, especially because of the regurgitation or the septal defects and things like that. Remember, with any pulmonary atresia, you have zero blood flow going to the lungs until you open that PDA up, and so you're going to have this big blacked out looking chest. You're not going to have any pulmonary blood flow, and so you're going to have greatly decreased pulmonary vascular markings. Initial stabilization, absolutely no different. You need to increase that pulmonary blood flow by opening up that ductus arteriosus, giving them prostaglandins, and we want to get their saturations above 75%, just like anything else. All right, so we've talked about non-ductal dependent lesions. We've talked about cyanotic ductal dependent lesions, and now we're going to talk about left outflow tracts. These are all essentially like the same thing, but left outflow tracts, remember, these are also ductal dependent lesions, but they're ductal dependent not because they need to get blood to the lungs like all of those previous ones were. These ones are ductal dependent because they have some jacked up aorta, and so they need mixing from the pulmonary artery in order to improve blood pressure and blood flow coming out of the heart. All of these are very, very, very similar. So coarctation, we can see coarctation up at the top. I kind of already talked about coarctation like a little bit. So typically you're going to see that stenosis right there, right after the ductus arteriosus. Oh, there's a much better picture. So you have your aorta right here. You have your pulmonary artery. This is your ductus arteriosus right there. Your aorta should continue around very easily, but there's a big stenotic part of the pulmonary artery, or excuse me, of the aorta right there, and so it's restricting blood flow greatly. So you're going to have pretty good blood flow coming up right here. This is your left carotid, your right carotid, and your subclavian coming off of there. But as soon as you get past that carotid, then you basically just kill your blood pressure right there. And so unless you can open this back up and allow some more pulmonary arterial blood into the aorta, then you're going to have hugely decreased systemic blood flow there. So this is a coarctation baby with with a closing ductus, and you can see that they have basically no systemic blood flow whatsoever because the bolus just dies right at the right after the subclavian there. When you open that ductus arteriosus back up, then you allow a lot more blood flow, and though you are going to be a little cyanotic on coming through those arteries, it's going to be at least a lot more blood flow. Valvular stenosis or critical aortic valvular stenosis, which is just called AS or aortic stenosis. Typically, you're going to have that either bicuspid or unicuspid valve, so it's not a nice tricuspid valve, and it's just incompetent. It can leak too, so the blood flow can come back in here during diastole, and it just doesn't allow for a lot of flow, and so you need to do the same exact thing, right? So it doesn't allow for a lot of flow. You need to open that PDA, or excuse me, open that that ductus arteriosus back up, so that way you can get some good flow coming through there. Interruption of the aortic arch. This is a very, very sick baby. So you can see up at the top right here that the aortic arch doesn't continue through where it should be. So the pulmonary artery needs to open back up so that way you can give mixed blood into the descending aorta on these babies. And then a hypoplastic left heart, you can see that left ventricle is teeny, teeny, tiny. Typically, also you're going to have very small aorta. Oftentimes it's going to be accompanied with coarctation, which this baby also has some coarctation shown on this photo right here. So if you open it back up with prostaglandins, you're going to have a lot of mixed blood, but at least you'll have a lot more aortic flow coming from that PA. Remember that with all of these outflow obstructions, oftentimes symptoms are going to coincide with the closing of the ductus arteriosus in those first 10 days of life, and they have the same symptoms as everybody else. So tachypnea, poor feeding, irritability, all that good stuff, or bad stuff. Initial stabilization is no difference. We need to improve systemic blood flow. We can potentially be giving these kiddos some inotropic medications. Oftentimes, we're going to have to intubate them. We'll start them on prostaglandins. Unlike the previous ones where we have those ductal dependent lesions, pulmonary lesions. With these ones, we do want to avoid hyperoxia because remember that hyperoxia is going to decrease pulmonary vascular resistance and increase constriction of the ductus arteriosus, which we do not want to do in these kiddos. And so maintain oxygen saturation somewhere between 75 and 85% on these kiddos. We don't want to necessarily super dilate the pulmonary vasculature and as it says here, at the expense of systemic perfusion. So make sure that we're giving these kiddos inotropic medications if we need to, and maintain those sats in the 70s or 80s. And that is all we've got. All right, everybody, go ahead and take the quiz for it, and hopefully you feel well prepared to be on the neonatal team now.